So good morning, everyone, and welcome to the WellMed Charitable Foundation's Caregiver Teleconnection session. We have a wonderful presentation scheduled today. Understanding the neuropathology of Alzheimer's disease and related dementias. And I would like you to meet Jeff Darling, PhD, and he's going to tell you a little bit about his background and then go on with his presentation.
Thank you so much. So I just wanted to start by saying thank you all for having me here today. I appreciate the opportunity to talk. A bit about me. So my name is Jeff Darling. I have a PhD in neuroscience, and I specialize in the fields of neuroscience, neuroinflammation, and neurodegenerative diseases. Today, we're going to be focusing mostly on Alzheimer's disease, but I have over the past decade or so studied a litany of other related dementias and disorders. So if you have any questions, feel free to ask about that. Today's talk is focused on understanding Alzheimer's disease dementia, some of the neuropathology underlying that. And then I also wanted to touch a little bit more, and I don't think I put this initially, but I want to talk about brain PET imaging. Recently, some advancements in therapeutics have come forward, and as a result, being diagnosed as early as possible with Alzheimer's disease or the course of the disorder is more important than ever. So I really want to highlight a specific avenue of which that process can be undertaken. I am a medical science liaison in that my profession is medical education, and I work for Life Molecular Imaging, which is a company that specializes in the diagnostic pathway for Alzheimer's. And we've already mentioned it before, but if you have any questions, feel free to either put it in the chat or put up a hand raise emoji or interrupt me along the way. I want this to be as warm and comfortable as possible conversation-wise, and I'm always happy to answer questions.
And if you're on the phone, just press *6 to unmute yourself. I have a website where I can see that, and I'll call on you.
Perfect. So we're ready to get underway? Cool.
Take it away.
So just some general disclosure, since I work in the private sector, I am a full-time employee at Life Molecular Imaging, so it's important to point that out. I've already went through my expertise to some degree. I also think it's important to point out that I am not a medical doctor. I'm a PhD, so the purpose of this is for educational purposes only. It's not for rendering medical advice or professional services.
Thank you.
I'm going to be going through this talk kind of in two parts. The first is just general understanding of Alzheimer's disease, its pathology, its biomarkers, the prevalence, the evolution of a diagnosis and the evolution of the disease. We're going to be talking about amyloid and tau, which are two really important hallmarks in Alzheimer's disease. And then we're going to look at some images, which I think is one of the more fun aspects of the talk. So if you have any questions where you want to get more granular into some of this, I'm just providing an overview. But if you want some more specifics, please let me know. And then in addition to that, the second half is we're going to be talking about a diagnostic pathway, which is in brain PET imaging. So we'll be talking about target demographic for a PET scan, what is a brain PET scan, comparison to other scans that people get, CT and MRI, for example, and where you can get these scans, why we use them, and the A to Z process of getting them to kind of demystify it a little bit and remove some of that fear you might have in terms of either advocating for yourself or a loved one, someone you're a caregiver for, or if you're a healthcare provider, demystifying some of the science behind it as well. So first half, understanding Alzheimer's disease, dementia, brain pathology, and biomarkers. So it's important when we're discussing Alzheimer's and dementia to remember that they are not 100% equivalent, and that there's this larger umbrella that is dementia that encompasses Alzheimer's disease. So dementia itself is an umbrella term for the loss of memory and other thinking abilities severe enough to interfere with our daily lives. And while Alzheimer's is the most common, it's not the only form of dementia. You have vascular-related dementia, Lewy body disease, frontotemporal dementia, Huntington's, or often a mix of these pathologies together. So some key terms you might hear me use: dementia, not just a specific disease, but an overall term that describes these wide ranges of symptoms. That includes Alzheimer's. Alzheimer's itself is a type of dementia that causes problems with memory, thinking, and behavior. Usually it develops slowly, but then tends to get worse over time, becoming severe enough to interfere with our daily tasks of life. And then you'll also hear me refer to mild cognitive impairment, MCI, which is an earlier stage of memory loss or other cognitive ability loss that may be a precursor to the onset of Alzheimer's disease, where you start to see changes in daily living. And it's important to note that one of the reasons we think so closely of Alzheimer's and dementia is that 60 to 80% of those living with Alzheimer's disease represent that dementia population. So it's a very large chunk of dementia-related issues. And as the fact that it's the most common cause of dementia, that number is also growing over time. So right now, 2022, about 6.5 million Americans are living over the age of 65 with Alzheimer's disease dementia. It's the 6th leading cause of death in the United States. It's one of the largest leading causes of death in Texas, which is where I reside. And it's a leading cause of disability and morbidity. And it's increasing over the last decade. By 2050, in fact, so right now we're saying 6.5 million. In about 30 years, we're looking to see that number double to nearly 13 million people, which is a pretty drastic increase in terms of the population living with Alzheimer's disease. And I was discussing with Evelyn a little bit earlier, but one of the unsung aspects of Alzheimer's disease is not just the patients or the persons living with Alzheimer's disease themselves, but also the caregivers, the loved ones, the healthcare providers, the people who are at home who are helping take care of persons with Alzheimer's disease. Over 11 million people are unpaid, for example. And things like this come with a very large financial burden. So on average right now, about $321 billion goes into Alzheimer's disease and other dementia-related care, and that's projected to triple by 2050. So
And what did you say about Texas?
So in Texas, Alzheimer's disease in persons over the age of 65 is one of the leading causes of death.
Are you serious?
Yes. And that tends to be the case in most states, but it's a very large contributor in terms of the older population and morbidity.
And that's usually pneumonia, choking,
Yes.
things like that.
Yeah. Anything that coincides with degradation of the brain and loss of motor functions, things of that nature. Absolutely.
Thank you.
So when we're talking about this degradation of the brain or what changes with Alzheimer's disease, it's important to reflect on what a healthy aging brain looks like and on a cellular level, what is actually changing. So a healthy human brain contains tens of billions of neurons, right? And these are these hyper specialized cells that process and transmit information via electrical and chemical signals. So they're sending messages to each other, to other parts of the body, to muscles, to organs. And this propagation, this sending of information is what allows us to think, to function, to speak, and live our daily lives. And these cells have 3 main components that do this. So you can kind of think of it on your hand as, here, I'll get it out of the sun, sorry. The beam of light is that it's peak right now in my house. So when we think of a neuron, we can think of the sensory modalities that receive the signal that are then transmitted. So those are dendrites to a cell body, which can process information, build proteins, and then those send and propagate information down an axon, which is releasing that information, that messenger, to the next set of cells. So throughout your brain, you have this big network of healthy neurons that are communicating all the time and undergoing these biological processes that allow for communication, metabolism, repair, modeling, and regeneration, both in the brain and then throughout the body. Now, in Alzheimer's disease, these functions start to degrade somewhat. So here I have outlined on the left is going to be a healthy brain, and on the right, we're going to have someone with severe Alzheimer's disease. And already visually, you can start to see some differences, but if we zoom in, we see this on a cellular and molecular level as well. And that in your healthy brain, you have these neurons with these dendrites, axons, tightly bundled, communicating with each other. You have gray matter in the cerebral cortex on the outside with white matter on the inside. And you have structures that are related to memory that are functioning properly, like the hippocampus, for example. And in an Alzheimer's disease brain, you start to see some changes. So you see shrinking of the cortex or atrophy. You see an enlargement of the ventricles, which is what carries cerebral spinal fluid, a fluid in the brain. You have shrinkage in important structures like the hippocampus. So one of the issues we see with Alzheimer's disease is memory loss, right? Or the inability to have recall of really important memories for daily living. And part of that is due to shrinkage and atrophy of a structure called the hippocampus. And that's one of the earliest structures to be affected in Alzheimer's disease, which is why we see that as one of the earliest symptoms. And what we have learned over time is what coincides with some of these symptoms and the shrinking and atrophy is the development of some proteins that are coinciding with damage to neurons and nerve cells, and that is tau and amyloid. And tau exists within the cell. It's an intracellular protein that builds up, and amyloid plaques exist in this extracellular space, kind of floating around the neurons. And over time, we have buildup with these proteins coinciding with decreased cognition and atrophy of the brain in an Alzheimer's person living with Alzheimer's. And so here's some real life slices where you can actually see some physical differences within the brain of a healthy brain and a buildup of these tau plaques and tangles that you can actually see under a microscope.
Wow.
Yes, you had a question?
Gina, you're on mute.
Sorry. If somebody has amyloid plaques, well, I don't know if they call them plaques, but amyloid proteins in their heart, are they likely to have them in their brain too?
So there is some link to amyloid in the heart, so it's called cardiac amyloidosis. To what degree there is traveling or coinciding, I would have to check on that for you. I do know some experts in cardiac amyloidosis, and that's one of the issues with some diagnostic measures is blood, for example. If you're measuring amyloid, is it from the brain that you're tracking that, or is it from some buildup in the heart, for example? To what degree they coincide, I couldn't tell you the exact answer, but I think it is a very definite possibility, and both can carry some severe consequences as they build up over time. So I apologize for not knowing the exact answer. It's a wonderful question, actually, and I think something that's really being actively studied right now.
Thank you.
Yeah.
Thank you.
And so when we're talking about the development of things like Alzheimer's disease or cardiac amyloidosis, there's phases, right? There's onset of symptomology, and with Alzheimer's disease, a period of cognitive decline. And so Alzheimer's disease is a spectrum that has a long asymptomatic period followed by cognitive decline that's pretty sharp. So, as we all get older, we experience healthy aging, which has this slow decline, typical memory loss, where my keys go, or I don't really remember what floor I parked my car on. And so you see some decreases of cognitive function as we get older. What happens with Alzheimer's disease is you have this long preclinical period that's very similar to normal aging, and then an increase in cognitive dysfunction with that mild cognitive impairment, and then slowly a sharper decrease as we enter the dementia-related part of this disease. So in preclinical decline, maybe some slight changes in episodic memory, our ability to recall things, no real obvious brain pathology. And then some about 3.5 years before that MCI diagnosis. And then as we approach mild cognitive impairments, you'll see an acceleration of that cognitive decline. And maybe the subject with Alzheimer's is starting to perceive that cognitive decline themselves. Maybe they're more aware of it. Maybe some family members are becoming more aware. And then eventually Alzheimer's disease, dementia onset, where it's more severe, loss of life and independence, and severe loss of brain tissue. So we have a question from the audience from Lynette. Why would more people have this disease by 2050 when researchers have more evidence of the causes and they are now being more implemented in the medical field to help slow down the process? So that's an excellent question. So a few things for the increase in people with Alzheimer's disease, one of which is increases in general population. So the world is growing, right? There's going to be more people in 2050 than there are now. Also, people are living longer than ever. And studies have shown that despite some of the medical breakthroughs that we have in terms of therapies and slowing the disorders, currently, there's no cure for Alzheimer's. And the therapies that we have are mostly symptomatic treating. There have been some breakthroughs in the last couple of years with Aduhelm and lecanemab, which are two drugs that I can talk about later. But those are just slowing the cognitive decline. They're not preventing the disease altogether. So you'll have more people living longer, and as a result, more people succumbing to Alzheimer's disease. Hopefully that answered your question. If you have a follow-up to that, I'm happy to launch into it more. But ideally, with the breakthroughs in science, we can reduce that number so it's not nearly as large as what they're predicting. So just some evolution of Alzheimer's disease diagnosis in general, just some historical background so you can see contextually how far we've come in the science. So the discovery of Alzheimer's disease was by Dr. Alzheimer, a lecturer at Munich University Hospital, where he reported an unusual case involving peculiar severe disease process of the cerebral cortex, so brain matter, that coincided with memory loss and microscopic brain changes. So, even 100 years ago, they were starting to do autopsies in brains, looking at these changes and noticing how they coincided in patients with memory loss. Eventually, those patients exhibited long-term symptomatic deterioration and ultimately death. And the very first case was Augusta Dieter, born in 1850. She was the first person to officially be diagnosed with Alzheimer's disease at the age of 50 in 1901. And she's quoted to have said, "I've lost myself, so to say," which I think is such a profound statement when we're talking about Alzheimer's disease and related dementias, because we're dealing with cognition, with memory, and it's so hard to watch these changes over time. And I think especially the healthcare providers and caregivers in this group can really understand that the most, and how scary this whole process can be, and especially those with Alzheimer's disease watching these changes happen in real time. So I think it's really important to highlight that and remember that even 100 years ago, as we were learning about this, at least with science now, we have a descriptor, but that it does seem scary. And hopefully through talks like these, we can demystify that process to some degree.
Because we lose them too.
Yes, exactly. And Augusta Dieter did pass away in 1955, but it's through patients like her that we are able now to make some of the breakthroughs that we have and shed a little more hope on the diseases and disorders. And through that science, we've really come a long way in terms of understanding some of the pathology that underlies Alzheimer's disease. So for example, I brought up tau tangles and beta amyloid plaques. We now know that those are the two main hallmark proteins that we see in Alzheimer's brains. So the expression of plaques and tangles in Alzheimer's is really the hallmark that allows us to diagnose someone in a biological sense with Alzheimer's disease. So those plaques of amyloid accumulate outside of the neurons. Neurofibrillary tau tangles present inside the neurons. And because we have these markers biologically, we can now understand and test for them as a way of diagnosing someone with Alzheimer's. So previously, Dr. Alzheimer's, for example, the only way to diagnose and visualize the hallmarks was at autopsy. But now we talked a little bit about blood, for example. There's also cerebral spinal fluid, CSF. And today I'm going to be talking more at length about PET scans, bioimaging for these biomarkers. We can actually begin to see them in real time in patients who are still with us, which really helps in terms of outreach and therapeutic opportunities to either slow or decrease symptomology of the disease itself. So why are these biomarkers needed? Just I spoiled it before I asked it. It really helps us in terms of our therapeutic targeting. So this is a symptom overlap between Alzheimer's disease map. And so we have that preclinical phase that I've already described. No observable symptoms in stage 1 of Alzheimer's disease, stage 2 describing the earliest detectable cognitive decline, but still fairly early on. Mild cognitive impairment is where you're starting to see that decrease in cognitive function, followed by mild dementia, more moderate, and then severe dementia, where you see that really sharp decrease in cognitive impairment, causing significant functional loss that differentiates itself from earlier aspects of the disorder. And previously, diagnosing along this path has been relatively difficult because of the lack of biomarkers. And when we talk about therapeutics and treatments and proactive planning, by understanding the different stages and being able to diagnose someone earlier and earlier, we can actually modify the therapies and treatments that we give. So in the earliest stages, mild cognitive impairment, for example, you can start to modify the disease itself through a combination of different therapies, exercise. I'll show some clinical trials later and some data surrounding that, but you're actually able to modify the disease itself and in theory, slow it down. What becomes more difficult, remember when I showed that graph, that sharp decline, is when you get into later stages of dementia, it's harder to modify the disease itself. So a lot of the therapies you see are symptom related. So non-disease modifying therapies for symptom relief. And that's also where you see the largest amount of clinical trial failures, where they try and reverse the disease, but it's a little too late. So early diagnosis, early identification of the disease allows for earlier intervention and hopefully more therapeutic efficacy. And so that brings me to Aduhelm. So many on the call today might have heard of Aduhelm or aducanumab, which is a monoclonal therapy that targets amyloid. So when we talk about amyloid and tau, amyloid is the first to begin appearing, sometimes even 20 years before cognitive decline begins. And then tau begins to appear more closely related to the onset of cognitive impairment. Aduhelm came out in June 7th, 2021, and was the first of its kind to remove amyloid plaques from the brain and to begin to show some efficacy in terms of slowing the cognitive decline related to Alzheimer's disease. So it was the first to be FDA approved, and it was approved on its ability to remove amyloid plaques. And unfortunately, we're still dealing with the ongoing studies as to the efficacy of these types of treatments. But I will say this is the first therapeutic avenue that's been able to show some benefits for patients with Alzheimer's disease. So I'm just going to reflect on some questions really fast before I continue. So we have Gina, do caregivers start having memory problems because of stress, or is it likely they have inherited it? So I do think some stress-related memory impairment is a thing. So my background beyond just basic neurodegenerative diseases, I also worked in a learning and memory lab, and stress can be inhibitory towards memory recall. In terms of Alzheimer's disease, there are some genetic components for inheritance in that degree, but the majority of Alzheimer's related cases are not necessarily genetically linked, and still requires ongoing study. So with Aduhelm, one hallmark of the pathology underlying Alzheimer's disease can be addressed. So does removing amyloid cause some kind of cognitive benefit? And we're seeing yes. And many of you may have heard of lecanemab, which released its phase 3 clinical trial results a few weeks ago in San Francisco at a CTAD conference. I happen to be lucky enough to be there, where we saw some more efficacious results surrounding the removal of amyloid and cognitive benefits and self-reported daily living. So it does seem like these therapeutics might have a chance of giving us some hope, but it is still too early to be able to say grand slam, I think, if you like baseball terms. And so that's removing amyloid. There's also some clinical phase trials related to tau, which is the other hallmark. But what you'll notice is the majority of them are still in phase 1 of clinical trials. So they're still very early on. So the FDA approval happens after this phase 3, which means getting into the average patient still takes a while. So while amyloid's a little bit further along, tau itself still has some ways to go.
So Angie had some questions about some of the clinical trials going on. Did you see that in the chat room?
I missed it, but I can scroll up. So Angie said, speaking of early detection, I recently signed up to participate in Alzheimer's prevention trial. Thank you for the link. So the study through a series of quarterly no-cost memory tests. Yes, so Angie linked to a clinical trial. I think clinical trials are really important to participate in if you are eligible, because it I feel like those are the bravest, not in terms of risk, but in terms of faith and willingness to push the science forward. And it's through clinical trials like the one Angie mentioned and these that allow us to develop these therapeutics that can help people earlier and earlier. And I'm very happy to leave my email and help anyone that wants a link to some of the clinical trials that are ongoing in the United States. Our company participates in some with its bioimaging, but I can send you a link for basic FDA related or NIH related clinical trials, just a database to search through, which can take all the time in the world if you want to sort through.
Jeff, we always send out resources when we send out the post-session questionnaire. So if you just send me the link, I can get it out to everybody.
Yeah, absolutely. So in terms of diagnosis, so I've been hinting at this all along, and that earlier diagnosis is so paramount in terms of getting to not just symptom treatment, but also slowing of the decline of cognitive disorder of Alzheimer's disease. And there's not just one single test. So I'm going to be talking today, here, I'll shift to this side of the light. So I'm going to be talking mostly about PET scans today, but it's important to know that there's lots of forms of diagnosis and they are all critical in formally diagnosing someone with Alzheimer's disease. It's an all hands on deck kind of process. And I think the most obvious and the one we see most readily used is medical and family history. We know our loved ones, we know how they act on a daily basis, we know how we think, we know when we're starting to forget things. So understanding our medical and family history is paramount in terms of working with a physician to be diagnosed with Alzheimer's disease. And then there are also cognitive tests, the mini mental state exam, for example, as well as physical and neurological exams, looking at symptoms. There's also fluid markers, which we talked about to some degree, blood and CSF through a lumbar puncture, for example. And then there's imaging biomarkers. So there's different imaging sources, MRI and CT, which get to a more structural level of scans. And then there's also amyloid and tau PET scans, which I'm going to be showing some images of, which is a way to really see the expression of these proteins in an Alzheimer's disease patient in real time. So here's an example. So this is an amyloid brain PET scan, which allows, we like to see, it makes the invisible visible. You can see amyloid plaques in a living patient. So we have a negative scan up top and a positive scan on the bottom. And these are structures where we see buildup of amyloid over time in patients with Alzheimer's disease. And the way these scans are read is a yes or a no. So either you have it or you don't. And the difficulty with Alzheimer's disease is over time, you see increases in expression of these proteins throughout the brain, which means earlier on, there's less, which might make it more difficult to say yes or no. But there's pretty strong efficacy in terms of trained readers being able to look at these scans and saying, yes, you see this increase in expression versus no, you don't. And it gets starker and starker with time. And I'm going to be breaking down sort of the process of this a little bit more. But this is generally what an amyloid PET scan would look like in a positive versus negative subject.
Excuse me, Jeff. So I'm a little confused. So the positive scan means that somebody does have Alzheimer's disease. Okay.
I'll say this, it means the presence of amyloid. Okay. So to fully diagnose someone, it takes more than just amyloid. So amyloid and tau need to be present along with some of these cognitive scores and working with your medical doctor for a formal diagnosis. This is just an added tool in the tool belt where you can see that amyloid is present. And as a result, you can say the increased likelihood of someone having Alzheimer's is there.
Thank you.
And coinciding with that, I also have some images of tau PET scans. So this is still ongoing in terms of development. Amyloid's a little bit more established, but you can see here, so this is a healthy control up top and an Alzheimer's disease subject with about mild cognitive disorder on the bottom. And you can see in the top portion, so the way it works, it's kind of like a heat map. The redder, the darker the signal, the more tau you have. And in this healthy brain, you don't really see any red, there's no green. That's what I want my brain to look like if I get a tau PET scan, right? And in the bottom portion, you start to see these hot spots that correspond. And some of this is just flowing of the tracer, and I'll talk about that to some degrees. That's why you see some in the sinus cavity. But in terms of brain scan, where we would look for the tau, you see it in these hot spots in a subject with Alzheimer's disease that you don't see in our healthy control. And that's corresponding with regions where we see cognitive decline emerging. So the hippocampus, that area related for memory, the medial temporal lobe, for example, is one of the earlier regions where you see tau deposition and one of the first where you start to see atrophy and cognitive decline emerging from.
Lynette wanted to know if the scans have ever been wrong.
Yeah, so I think with any science, there's an ongoing process of development and a lot of there's working on quantification, which removes some human error, but there is human error involved in anything reading a scan, whether you're dealing with a cancer patient or looking at an x-ray. What's nice about PET scans is that there are trained professionals, trained doctors who undergo a process where they learn how to read these scans, and always reducing the rate of error is paramount to try and alleviate some of that process. So while yes, there are some reader errors that may take place, I think everyone wants to get a diagnosis like this correct. And the benefit of a PET scan is it helps reduce human error in other avenues, such as cognitive scoring, or just meeting with your physician alone. So it's an added reduction in overall error, I think, when you add in these PET scans. Hopefully that answered your question. And so here I just have another example. So this is a series of patients, all of which are tau positive, showing that you can also not just show yes, it's there or no, but to some degree, you can also track progression of expression. So starting in one region, you can start to see an increase in expression as this subject with Alzheimer's disease progresses through the disease. So utilizing these scans, you can also see how much tau has expanded within the brain, not just that it's there in the first place, which is really important when you coincide that with cognitive scores and looking at how progressed someone is in AD entirely. So I've shown you some of these images, and if you're like me growing up, the ideas of getting a CT or an MRI or a PET scan is kind of scary, because if you've never had it before, you don't really know what the process is. Or if you have a loved one who's undergoing it and you've never had it, how do you explain to them, especially if they're having some cognitive difficulties, how do you temper the fear to some degree? So I'm right there with you in that understanding. So I'm hoping that, especially since diagnosis is so important and earlier the better, I want to demystify some of what getting a PET scan is like, just as a part of this presentation. So what does PET stand for? It stands for positron emission tomography. It's just a fancy way of saying that it's building a map of your brain utilizing this radioactively labeled tracer that you get injected via IV that emits positrons when it's interacting with a substance of interest. So in this case, tau or amyloid, and building a map of that in real time. So it's a
Love the picture.
Yes. This, unfortunately, I don't think these dogs will be there in the room to comfort, but maybe afterwards. But it's done by nuclear medicine experts on a special PET scanner to localize these tracers that are injected into the body. And so, can you take a PET scan if you have a pacemaker? So that's so the specifics about getting PET scans. And whether or not you can, or MRI, for example, or something that you specifically should talk with your physician about. So to that degree, I'll defer to the medical experts. Anything metal in your body, for example, you can't get an MRI. But that's something that a physician would readily be able to answer on just a basic primary care physician call. But that's an excellent question, Gina, and something that I can follow up on in terms of specifics, especially of locality of pacemaker and where. So I don't want to say yes and get it wrong, since again I'm just a neuroscientist and I know less about pacemakers themselves. So amyloid PET brain scans, I showed you some of these images already. A trained so one of the things we talked about was error rates. So a trained reader is trained to know that in the frontal lobe, for example, in a negative patient, you'll see these star-like patterns of white to gray matter that disappears in a positive patient. Actually, here, let me blow this up for you. There we go. So now you can see even more zoomed in. Or in the lateral temporal lobes, you see this clear definition of these maybe like mountains and peaks that you lose in a positive patient. Or you have this donut hole-like area in the posterior cingulate that disappears in a positive subject. Or in the parietal lobes, again, you start to lose some of that definition. So readers are trained clearly when they see these in these four brain regions to say yes or no, it's present. And that can be utilized by your primary care physician or your neurologist to help you with your Alzheimer's disease diagnosis. So brain versus MRI versus CT. So in a PET scan, we're looking for the presence of these proteins, tau, amyloid, for example. MRIs are more looking at just overall structures within the brain, which is useful in terms of looking at your ventricles for atrophy, which we said, remember, there's enlargement of your ventricles with Alzheimer's disease, or atrophying of structures throughout the brain. I should say, we mentioned earlier that patients who have metal objects cannot have an MRI, for example, but generally they get very good resolution, image quality. One of the downsides is that they are more expensive than a CT scan, for example. CT scan being computer tomography, again, building a map, also good at looking at structures, but it's quicker than an MRI, it's faster, but it's less expensive, and it does get generally good image resolution, but not to the degree that an MRI would. So a little bit different in terms of what we're looking at. PET scans, where we're looking specifically at a target of interest versus something more structural that you'll have in an MRI, for example. So why do we do PET scans? So for numerous reasons. You can look at things like glucose metabolism or changes in function in real time through the brain with something called an FDG scan. You can look at whether or not plus or minus, yes or no, to the presence of amyloid or tau in the brain. Other tracers, so it's very common that you'll see PET scans done for oncological purposes. So looking at cancer expression, presence of cancer in the brain, and other metastatic diseases. So it's something a little bit more targeted when we're talking about having a PET scan done. So in my final minutes, so that I don't drone on too long, I kind of wanted to give an A to Z of what the process is actually like, so that when you're walking through the door, you can say, hey, yes, explain it to me, but at least my friend Jeff explained to me the basics of what a PET scan is going to be like, what the process is. So the entire process takes a little under 2 hours. It doesn't mean for that 2 hours you're doing something yourself, but time-wise, let's say you go in at 1 o'clock, generally you can be out by about 3 o'clock, let's say, from the whole process. There's no restrictions on eating or drinking or medicine. You can wear comfy clothes. And what'll happen is you'll lay down, the med tech will start an IV in your arm, which injects this amyloid tracer, which then travels throughout your body. And the radioactive component of the tracer is what is picked up by the scanner. So it's not necessarily a dye, it's something that emits those positrons. That's the part of the positron emission tomography of PET. So it'll circulate 30 to 130 minutes, and then you'll receive your scan. So it requires a little bit of time of uptake to travel throughout the body and bind before you can get the scan and actually measure it. So the patient prep and injection. Next, you'll be positioned in the scanner itself. So here we have a little picture of what the scanner might look like. The tech will get you positioned on the imaging table. It's fairly comfortable. I've been in one time, I've had it done myself, and it was pretty comfy. They have these nice little pads that you get to lay down on. It's not quite like taking a nap, but it's comfortable. They'll put your knees up to help you relax. Sometimes they'll use a body strap, which is just a light little strap that goes over you just to make sure you're snug and not moving too much. Sometimes we'll have subjects that are a little bit more mobile, so a body strap can help with that.
Is it as noisy as an MRI?
I don't believe so. There is some noise component as you're being scanned, but MRIs are pretty loud. Yeah, this is not so much. Next, you'll what's really important about a PET scan is head immobility, and that if you're moving while you're being scanned, the scans will be taken in different positions. And you saw those images, they're very specific in terms of what they're looking for in regional specificity. So it's very important for proper head position. So tech will position your head in the camera's head holder. You can see these little sides right here that help keep the head in place. So they're not pushing, it's more just so you aren't tilting your head. And you might right now instinctively, if you hear something out of your ear, turn your head. What's nice about this part is having just that slight little pressure reminds you not to move your head through the procedure. So small cushions on the side of your head, just to remind you to hold still. In addition to that, not always, but sometimes they'll use these chin straps and forehead straps to make sure you're secure as well, just to make sure your head is perfectly still. And the reason stillness is so important is any kind of blurring makes it more difficult for a reader. So getting back to that earlier question about getting a scan right or wrong, the stillness of the image really contributes to the accuracy of the scan itself. and so methods like this are what really reduce that error rate. And a tech afterwards can look at the scan and know whether or not that movement took place. And then finally, so there's the acquisition of the scan. Holding still, depending on the tracer, depending on what they're looking at, can be anywhere between 10, 20, maybe even 30 minutes. Holding still, and then you'll get your scan and you'll be done. Then it'll be sent off to a reader where they'll be able to evaluate it and meet with your doctor and discuss the results. So yeah, like I said, blurry images can make it difficult for the nuclear medicine physician to interpret or read the scan correctly. But otherwise, if everything goes accordingly, you should get nice, beautiful images. And so then the follow-up with that is in terms of amyloid, at least with our product, it's read very simply as a positive or negative. And in conjunction with the tau scan, for example, knowing, yes, you have amyloid and tau really helps in a confirmation diagnosis with Alzheimer's disease. And the benefit of that is that you can then channel people into the proper therapeutic avenues. So this is just more summary of what I long-windedly said before, 2 to 3 days. Nothing new on this slide, apologies. So I finally want to just bring this one up to really highlight the reason that I bring up PET scans and diagnoses is we understand these biomarkers exist. Now we have an ability to see them in real time earlier than ever. Amyloid, you can see up to 20 years before signs of cognitive decline. And the ability to see that really highlights subjects in this region here, where you can start to see use of these disease-modifying drugs and combination therapies to reduce the rate of decline due to Alzheimer's disease and slow it down. Versus waiting too long, you start to see that it's really only symptom mitigation that's taking place.
Did you say 20 years?
Up to 20 years, people have been able to detect amyloid before cognitive decline.
Wow.
I mean, that's on the longer end, and often someone's going in without cognitive symptoms, so maybe they're part of a clinical trial as a healthy control. But there have been instances where someone's gone in as a healthy control for one of these studies, and it's picked up amyloid before they even knew that they might have Alzheimer's disease. And 10, 12 years later, now we have a patient who's got a higher load of amyloid and is now starting to see the early symptoms of Alzheimer's disease. So the power of these tools is pretty strong in its magnitude in terms of availability to help people earlier and earlier. So I just really wanted to highlight, and the reason I'm going into such detail on this diagnostic part of it is that these pathologies that we understand now coinciding with earlier diagnosis is really what's helping push the field forward. So there are some limitations. I would be remiss if I didn't say that there are risks with anything, right? So a positive scan does not fully establish diagnosis. Remember, we talked about all these different ways: blood, CSF, meeting with your doctor, these cognitive exams. So it takes a village to diagnose someone properly with Alzheimer's disease, but this is a really strong, I think, one of the best tools to do so. Also, in terms of safety and effectiveness, so we are using radio tracers. You can think of it as being similar to an X-ray. There's always some kind of radiation when you're using these products, which limits the amount of scans you can get done, for example. So talking with your primary care physician about that is something that's really important. Lynette asks, at what age should a person get a PET scan? So I think ultimately speaking with your physician on whether or not it's warranted is the most important thing. In terms of Alzheimer's disease, you're seeing people with these symptoms on the earlier side, anywhere from age 50 and up. But what I don't recommend is people just walk into their doctor's office if they're feeling perfectly healthy and asking to get a scan related to Alzheimer's disease, both because of the risk for things like radiation, but also you're limited in the number of scans you can get throughout a lifespan. So let's use those scans appropriately, especially in terms of medical resources. But what you should do is you should have active communication with your person you're providing care for, or your primary care physician, your neurologist, in terms of whether or not that's the proper avenue and option for you. And I don't think we've ever tested for AD in teenagers or children. So I would say that that's probably too young in terms of people to give these types of PET scans to. And so I discussed a little bit of the radiation exposure risk. repeated PET scans are not something you would necessarily want to do if you don't have to, like any major or minor medical procedure. So there is some inherent risk in that regard. So just as a summary, until recently, AD diagnosis really could only be done at autopsy, but now with these biomarkers, it makes it possible to visualize and identify these brain changes in living patients in real time, earlier and earlier than ever before. Alzheimer's disease itself is a spectrum that begins with this long asymptomatic period during which the disease is processing in the brain. And amyloid is one of the earliest detectable signs of AD, which is why you see blood markers, plasma, CSF, PET, all starting to target amyloid, as well as therapies. This early and accurate diagnosis for AD is important in terms of therapeutic avenues and windows. And use of amyloid PET is a technique that we can use for that early AD diagnosis. And intervening is getting more and more paramount in terms of helping people as soon as possible and slowing the disease, especially with the emergence of these disease-modifying drugs. PET brain scans and their results are an important part of information that helps guide patient management decisions for physicians, patients, and families, and can be used really strongly in conjunction with other avenues of diagnostics. And I hope today, just by briefly walking you through what a PET scan process is like, it helped demystify it to some degree and made it seem like a more palatable option for those who are seeking out a diagnostic avenue. And I think that's all I have. I think we have some more questions in the chat. For Mary, is it fair to ask for a PET scan at the age of 60 if a parent had Alzheimer's disease? I think if you have some kind of familial connection with Alzheimer's disease, especially as you're approaching your middle to late age, I think that's a really great conversation to have with your doctor. I think asking about options, and so one of the first avenues they have is those cognitive tests, right? They can discuss with you. That's a very simple way and a very quick way to see if there's any kind of concern. So maybe if you have the concerns that you might be having some symptoms, that's the time where you might ask your doctor if that's a possible avenue to partake in. But remember, there's lots of options that we can discuss beyond just PET scans, since that's, a more expensive option than a simple cognitive exam. But I do think it is important to always have an open avenue of conversation with your medical provider. Minerva asked, do a lot of insurance companies cover this procedure, or would it be more out of pocket? So that's the tough aspect, right? Is procedures like this do cost money. What you'll notice with the development of products such as Aduhelm, which I have highlighted here, is that there needs to be some kind of reimbursement coverage so that everyone can get these scans. So currently reimbursement is limited. So people in clinical trials obviously have reimbursement with that regard, or rebate programs, of which since I'm on the medical education side, I can talk less about those finances. So if you have questions, that's a follow-up that we can take to someone else. It's important for me to stay separate from that aspect. But that is a concern, is cost, and something that is actively being worked on in the medical field to make sure that everyone and all people who deserve and need coverage get it. Gina asked, how do you convince the person to agree to go to a neurologist and get these scans? I think that's often one of the toughest things, right? Is it's a scary process. And I think just in terms of having conversations about familial history, maybe some changes in memory, that's the start, is these conversations. And then I would hope talks like these that kind of demystify the process and make it seem just more like an everyday medical visit and just general maintenance. We go to our primary care physicians for checkups all the time, right? I think it's a really important thing to just include stuff like this in that conversation, to remind people that aging is normal. Aging is a natural process, and it's important when we notice changes that we confront them so that we age as gracefully and wonderfully as possible.
If you don't mind, Jeff, I'd like to add on to that. I think we were talking a little bit beforehand about the fact that so many people, particularly spouses, because people live together, that the kind of ongoing memory loss, forgetfulness, it happens slowly and every day. And so you just think, oh, they're getting old, but maybe they're not just getting old. If they're aging at a faster rate than you, we don't want to be in denial, because that denial will keep people from getting that early diagnosis. If there are changes, figure out what's going on, go to your doctor, ask them for just what Jeff said. Can we have some testing here? Don't worry, that it's going to be dementia, because if it is dementia, you want to know earlier rather than later. And you're a behavioral guy, Jeff. What do you say?
My response is whatever it takes in terms of open conversation, and whenever you see changes that are abnormal, that's any yellow flag is a red flag in terms of dealing with diseases with quick decline when on approach, especially with a loved one. I mean, we call ourselves loved ones for a reason, right? And part of that is that sympathy and empathy that we can give by having the conversations themselves and seeking help when it's needed.
Can you get long-term care insurance after being diagnosed with dementia?
Unfortunately, that might be a little bit out of my wheelhouse. So if there's
I can tell you that you cannot. You cannot. How do you convince? Okay, we already read that one. All right, come on, more questions, folks. We've got this.
I have a question I posed in the chat that I think got missed, and it's just how often do we see markers, and not we, researchers see markers for dementia or Alzheimer's, and then no resulting symptoms. Somebody lives another 20 years. Here I'm thinking of, like, I think I recall something being called a nun study, where a group of nuns lived together and were cognitively intact, playing cards. They passed, and then they found that there were, in fact, a lot of markers for dementia. So I'm just curious about that.
Hey, Reba, that is an excellent question. And actually, the nun study is one of my absolute favorite studies in the neurodegenerative disease space because it's so interesting. So the quick and dirty of the nun study is that there's a convent where to join the convent, you have to write a brief biography of yourself describing where you were before you joined the convent, your education. And if I recall correctly, the findings in the study were that you could better predict someone's outcome in terms of cognitive decline based off of familial history, in terms of education, in terms of exposure to knowledge and things like socioeconomic living growing up. But what was interesting is some of these nuns, when they would pass away, would be cognitively fine, normal aging, but full of amyloid. And it was confounding because the amyloid hypothesis says as you build up amyloid, your risk for Alzheimer's disease increases. So now where the field is going is that not amyloid in and of itself isn't enough to say you have Alzheimer's disease or to show the cognitive decline. Tau, in addition to that, is more closely linked to cognitive decline. So you do have these subjects that show increases in amyloid that stay cognitively intact. And the question is that just because they have a greater compensatory mechanism? So as you see this atrophy within the brain, is it from a healthier baseline and acting as a protective buffer for the cognitive decline? Or is there some kind of protective mechanism that's allowing for amyloid to develop but not tau? I think that's an ongoing question and something we're still trying to figure out, but I think is exactly where the field is in terms of listening and looking and going through the studies.
Thank you for explaining that. I would love to have a link to that study if possible. I mean, I'm not
Sure.
Just, it would be helpful. And in addition to that, I'm curious then, are you able in these PET scans to be able to determine what is the tau and what is the amyloid, or is it just, so somebody could have a lot of amyloid but very little tau, or no tau, or just, what about that?
So with these scans, you would have to have repeated scans because they're specific to the protein of interest. So first you would look at amyloid generally, since that's the one that appears first. And if someone's amyloid positive, then you're more likely to have a tau scan as a follow-up. And in terms of expression in the brain, they're a little bit different. Amyloid's more diffuse. So I think if we looked at this brain right here, you're more likely to see amyloid expression diffuse throughout the brain earlier on, whereas tau might start regionally and then slowly begin to move as the disease progresses. So in terms of the amounts, there's differences, but also stage of the disease differences in terms of onset. And in terms of being able to see them on a PET scan, those would be 2 separate PET scans. I hope that answered your question.
Yeah, it did. And is there can one take from those numbers any sort of idea about how many people in the general population might be able to in fact go in and get a PET scan and find that they've got some amyloid, primarily amyloid, let's just say, and not worry about it? It could be like, okay, well, you've got it, but you know what? There's still a 20 or 30% of the chance that you won't get dementia based upon what we're looking at. And then how can I get that study? Is just to back up to wanting to look at it?
Yeah, I think things are still a tad bit in the infancy in the field to have the strongest of statistics based off of that. So I don't have a strong enough answer in terms of the predictive ability based off of these scans for the general population as to those risks. I think I'm sure those studies are out there, but I admit that I'm probably ignorant as to the specific numbers. But I think as more people seek diagnostic pathways like this, we can build those kinds of databases that will be more helpful for physicians going forward. And I think when you go to the academic conferences that I like to geek out at every once in a while, I think those are the exact questions that are taking place and the exact kind of studies that are ongoing.
Shows you how great our participants are. They're
Yeah,
listening.
these are wonderful
Wanna know.
questions. Yeah.
Yes. So I'm sorry, but I'm going to have to call this to a close because of keeping people on time. If you said you were going to give the resource of your phone number or your email
Well, what I'll
address.
do is I'll type in the chat right now my email. So j.darling@lifemi.com. I'm more than happy to answer any follow-up questions that we didn't have time to get to, or to do it to the best of my ability, especially in terms of follow-ups. I can send out the NUN study. So if you just shoot me an email to that email, I can send you links to any and all resources that I have available.
Cool. And if you have any that you want to go out generally, like the NUN study and something else that you mentioned, you can send them to me and I'll make sure they go out with the post-session questionnaire, which we hope you all will fill out. It really helps us always improve what we're doing at the WellMed Charitable Foundation's Caregiver Teleconnection, and we need that. Now, if you're not registered, if you just got the link or the number from somebody, you'll need to call WellMed Charitable Foundation's customer service at 866-390-6491. And it's really important that you do that because if you're not registered, you won't get the resources and we want you to have them. So, and you'll also get the great monthly calendar. We only have one more this month of the presentations, and that's Avoiding the Potholes of the Dementia Journey with myself and Glenda Rogers. And I've been a social worker for 50 years working with elderly and their caregivers, elderly and disabled. And Glenda was the head of the AAA for many years here in Texas, or there in Texas. And so you're going to have two people who've heard a lot, and mostly from caregivers. And we're going to feed that back about what caregivers have said you can do to make your journey easier. So that's the one tomorrow at 11 o'clock Central Time. We hope to see you then. And I would also like to thank this incredible presenter. What a lot of information. You talk really fast, Jeff. You get a lot in there.
Good to know. I can slow down next time, but yes, I've been told a mile in a minute. Apologies.
No, thank you so much. And I'd like to thank our caregivers. You are the backbone of long-term care in the world. No question about that. And I'd like to thank the WellMed Charitable Foundation for supporting caregivers in their clinics, in their SOS offices, with all of the stress buster program that they run, and in community centers, at teleconnection sessions, and that information-filled website, which has a treasure trove of podcasts by experts like Jeff. And with that, I'm going to stop the recording. Send your questions to Jeff. He's amazing. If they're not specifically for Jeff, if they're caregiver questions, why don't you send them to the customer service line? And that line again is 866-390-6491. And I thank you all so much, particularly you, Jeff. You did a fabulous job.
Thank you so much.
Now we're going to stop the recording.